of the Mental Wellness Society live on LinkedIn. This will be recorded and broadcasted on all our different social media. But I want to recognize. First of all, I want to thank all the one of you joining. Particularly, we have today with us Dr. Lebovits, Dr. Kelly, Dr. Lawless. We will have Kotia Serinstone. We have Tiff Lawless. We have Dr. Leisman and Dr. Wallace. For now, more will join. If you have any question, please send your question in the chat, because we will select the question there of the question we want to answer. And anyway, we also indicate our email address. You can ask the question also at the email address. I promise every question will be answered. So the main speaker today are Dr. Wallach, Dr. Leisman, and Dr. Donkin. I am very pleased because this event, the presenters are actually in Israel, in Arkansas, in Florida, in Pennsylvania, and Texas, and more will join from everywhere. So let me present you the Mental Wellness Society in very few words. So the Mental Wellness Society have been created to advance mental wellness to fully enjoy living. So that's a professional international network of science academy practitioners to improve functionality by enhancing cognition and wellness. Today, one of the applications that we do is to be looking at innovation and technology and validating such new or not necessarily new innovation, to validate and to make sure with modern equipment we can prove that it have a valid effect and it have a valid contribution, because if not, what is not validated, we don't talk about it, because we try to be we try to take an approach of only expert and specialist knowing exactly what they talk about and being in verified, I would say, opinion. So we can help society, and we remove doubt, and we remove maybe this, maybe that. So that's very important. So we only work on data after having data proving that things are positive. So we are in decline. We are in. I have the next slide. Yes, thank you. We have 4 groups: health and wellness professional, agent of change, which is more for corporation, how to improve corporation, in terms of service to the personnel, on the organization, the team, on the runnability. Education and parenting, Gerry is the chair of that department actually. On psychology, life coaching, social work, and therapist professional for groups. Next slide. So we have 1,600 members now in 72 countries, including 45 states of United States. We have our own communication network, and we have also a reasonably big LinkedIn group for the Mental Wellness Society. Next. So I will present Professor Leisman in a few minutes, but let's keep that for now. So the Mental Wellness Society I've been involved in many things, including helping Ukraine from the very, very beginning week of the conflict, and looking always to initiative, I will not say which are orphan, but which needs white knight and support if we feel as a group that it's something which could contribute to better living and better life. And that's what we have. We will explain you today about BAUD, because what we did with BAUD is a cooperation between the Mental Wellness Society, Mind, Movement and Mood Wellness Centers, and BAUD. We definitely cooperated together. So let me first introduce to you Professor Leisman, because he is a key scientist and main scientist in our organization in the Mental Wellness Society, the founder of the Mental Wellness Society. He's also now recently senior advisor for science in M3 centers. That came after all the discovery he made about BAUD, after the validation, not before, but after. Few words about Dr. Leisman. First of all, when you know him more, you will see that ask any question to Dr. Leisman. If it's about brain, he knows. He created the Brain Institute in Israel, in America, and in Cuba. He is the only American scientist working in Cuba.
I'm not American.
I'm sorry?
I'm not American.
You're not American? No, you are Israeli. You are the
Correct.
only Israeli. You are the only Israeli. But he is a fellow in the Royal Society of Medicine. He is full professor of neurorehabilitation and science and research in University of Haifa, in University of Havana. He is a publisher of different scientific review on brain. He is organizing different conferences related to brain and cognition and movement. He has been publishing more than 401 publications in leading scientific journals, 186, 154 readers of his article, and more than 3,000 citations. If you want more detail, you can go to, hopefully, you should be able to see the, or ask us the link. But definitely, he knows those things because he's the first one to have discovered that fetuses have emotion. It gives you an idea of the micro analysis in which Dr. Leisman is involved. So, Dr. Leisman, I want to start with a question to you. What was your first impression about BAUD before you started the study? And
First,
now you're having scientifically evidence-based positive results.
well, the first impression was, "Are you kidding me? This thing isn't going to work." Second impression was, "Well, we can try it and see what happens." The third impression was after the data had been collected and the results were significant, positive, clinically changing, and objectively, and those decisions objectively determined. So I did 180 degrees reversal on that particular topic.
To the point that you accepted to have this live interview today to speak about BAUD, and you indicated that you were totally supporting the result of BAUD in specific area that you have been studying, because what we did not add in the study, we cannot guarantee it works, but we will be explaining with Dr. Wallach in what field. So in your own words, what can you say about the BAUD-BPM effect?
Well, if I were going to be talking about was there an effect or not, and Dr. Wallach can certainly do that after I'm finished, I would say that I haven't the foggiest idea why it works, nor do I want to even get into that rabbit hole. So my interest principally is there a significant clinical effect or is there not? And the answer is there is, but the but is the limitation or limiting factors, and that and they would be depends what it is that we studied and what the effect was with that. So we looked at least the Cuban team looked at anxiety, depression, post-trauma kinds of issues. As it related to depression, we didn't notice a significant effect, but as we related it to anxiety, and by extension, post-trauma, then the effect was significant. So without getting into the details of why, because we can actually do that, I can certainly speculate about why. As it relates to objective evidence, you'll hear that from Dr. Wallach, but globally speaking, there's a significant effect on individuals who are suffering from anxieties of various kinds.
Thank you so much. So I guess that's the moment to ask Dr. Wallace to present the result of the study. Hi, Dr. Wallace.
Hi, everybody. So I'm going to start off by saying that...
I'm sorry. Dr. Wallace is a psychologist. He's also doing biofeedback, and he's working in the biggest insurance and provider of health provider in Israel. And he knows about he's a person in our team following the research, coordinating the research in main M3 centers, making sure that establishing protocols and making sure that we follow protocols and looking at what are the results and what is comparable and what cannot be used because it's not following what he says. So there is not a study which does not go through Dr. Wallach, and that's what he does. So now that's why he can talk to you about the study we made with Dr. Leisman in Cuba.
So it's nice to meet everybody. Thank you for attending.
Celeste, can you put Dr. Wallach slides? And you will have to say next.
So we developed a study to look at the BAUD, the Bioacoustical Utilization Device, which has been around. Dr. Lawless had developed it many years ago, to look at the impact of it in treating distress. And we were trying to do this as really a neutral party and really examining how the device might help alleviate distress in a clinical population. And we want to see if this works and if its effects hold up relative to other treatments, or if it works better or the same as other treatments. So the first thing is we were looking at, well, what really is the stress? So next slide, please. And so distress is a response where there's a negative valence or a negative emotion or even a negative physiological reaction in response to an internal or an external stimuli or triggering event. And that response could be sadness, it could be stress, it could affect us socially and spiritually. We can have pain as well. And it could be going on from a variety of different causes. But again, the ultimate part here is that there's a negative experience that's occurring in different people. And oftentimes people, when they have distress, they feel that they're unable to cope with the changes when there's a disruption to their normal life activities, whether it's by disease or by change in their circumstance that's outside of normal control. Sometimes there's also distress to normal life events as well, but oftentimes the distress is experienced at a high level when a person feels that they're unable to cope or manage with the changes. The physiological changes would be something like heart rate changes, but psychologically we would feel maybe stressed out, feel anxious, feel sad, or even depressed. The physiological, like I said, would be heart rate, but it could also be blood pressure changes. And so again, these are an interactive response in the body as well. And if they're unresolved, the long-term presence of these experiences has a detrimental effect on the human body and on the human mind as well. And many people, unfortunately, lack the tools to adequately to resolve, reduce, or manage these experiences. And that's what we want to try to find a way, is to give them something that they can add to the tools that they already have to help with their experience. Next slide. And so if we look at the background for things like biofeedback and neurofeedback, this is not new science. Biofeedback has been shown to be effective in a variety of different therapeutic experiences. But in summary, very briefly, biofeedback is the process of giving a person information about their own body, and neurofeedback is the process of giving a person information about what's happening in their brain. And we can reinforce positive changes through conditioning or operant conditioning. So we could be looking at things like heart rate or respiration for regular biofeedback or electromyography. But where for neurofeedback, we're looking at brainwaves or EEG data. And the evidence has been present with multiple research studies in ADHD, with anxiety, hypertension, physiological diseases like Raynaud's, which affects circulation to the peripheral parts of the body, and even seizures. Next slide. And the BAUD or the BAUD-BPM is not a typical biofeedback or neurofeedback. What it really is it's creating a sound wave. And this is a novel application of an old treatment that's been around. There's been the use of drum beats in shamanic ritual healings that's been evidenced and shown in papers going back as far as the 80s, looking at older historical use of the drum beats in shamanic healing rituals. And the BAUD-BPM really harnesses this pattern of sounds and stimulates the nervous system via this auditory system. There's no monitoring of what's happening within the person as a rule, so that's why it's not biofeedback or neurofeedback. It is self-directed, so the person who's listening to the audio tone is controlling the device and is finding the tone that's appropriate for them, which means that there's going to be limited therapeutic or therapist involvement. So the therapist or the provider isn't directly going to need to control the device. The participant or the patient is the one that's using the device and is actively controlling it, which might mean that we're going to have shorter sessions because the device doesn't need to be for a 45-minute therapy session, and can be used in a very shorter period of time in the event during immediately if they need to, but they can also use it outside of the therapeutic session typically. There's no active conditioning or learning or retraining of the brainwaves. This is something that the person has a tool to use, just like they're going to, if somebody goes to exercise, if they're on the treadmill for 20 minutes or half an hour, they're having a health benefit of that. This is something that they get a direct benefit from using this. Next slide. And so the BAUD-BPM looks like the device pictured here. Currently, it has 4 knobs to control. 2 are for the volume, 1 for left ear, 1 for right ear, because the difference between the 2 ears is the key factor. There's a knob that controls the main sound frequency, and then there's a knob that controls the difference that's going to be experienced between the 2 ears. And that difference is the key factor of what we're looking at. Next slide. And so the binaural beat, frequency, pulse, or tone is what we're really looking at. And it's this difference that is experienced between 2 ears. So each ear will hear 1 frequency, and the device is going to be adjusted by the user, okay, to the main frequency initially by that main knob. And that's going to range between 0 and 350 hertz, okay? And once they find the right hertz tone, I guess it's really 0 to 330 as noted below, that's going to be the main sound. And then they're going to adjust with the disruptor knob between 1 and 20 hertz. And that's going to give us that binaural tone, the difference between the 2 ears, which is going to be experienced in the brain as a singular tone. Okay, it's combined in the brain, and that's the binaural tone or binaural frequency. Or in this case, we're talking binaural pulse maybe. Next slide. And so the goal of the 2 studies that we had done, the main study, which had an N of about 60, was to determine whether the BAUD-BPM would be effective in alleviating symptoms of emotional distress. And we wanted to collect, in the second study, a small subset of participants to look at the biological data from before and after treatment with BAUD to see if there was a change on functioning in the brain. Next slide. And so the method we had collected from 59 adult participants from 18 to 60, presenting in a hospital in Cuba. They were evaluated by 3 clinicians. They completed self-report measures, including for anxiety, post-traumatic stress disorder, COVID-related stress, or depression. We are not particularly looking at the depression in this in the outcome today. The depression results were non-significant, just to put that out there, but we found significant results for anxiety and distress. We had 4 treatment groups. We had the BAUD-BPM treatment group. We had the treatment as usual group, where they either had psychotherapy or medication, a sham treatment control group, and a waitlist control group. The protocol for the intervention with the BAUD was 8 sessions of 15 to 20 minutes, twice per week for 4 weeks. Next slide. And we collected measures before we started the study, during the process of the study at the end of the 4 weeks, and also we did follow-up 4 weeks after and 12 weeks after on anxiety, the COVID stress scale, and also the PTSD scale, or the PCL-5. Next slide. And if we look at anxiety on the main effect between the treatment groups, we found that there was a main effect for the treatment, okay, with a pretty strong, significant result. Next slide. And if we look at the subgroups here, we see between the treatment group and with BAUD and the traditional treatment that there's a non-significant difference. However, when we look, so it's just as effective, it looks like, as traditional treatment. When we look at BAUD to sham treatment, that there is a significant difference. And if we look at the difference between the traditional treatment and sham treatment and waitlist control, we also see a significant effect. So the BAUD, this is indicative of the BAUD intervention, or the BPM intervention, having reduced level on anxiety scores at the end of intervention. Next slide. When we looked at the COVID stress scale, again, a main effect between the different treatment groups. Next slide. And when we compare the BAUD to traditional treatment, we actually also see a significant difference here between time 1 and time 2. And when we look at between between group 1 and group 2, so we have between the 2 treatment groups. And when we look at between the treatment group and also the sham treatment, again, we're seeing a significant difference, indicating that the BAUD looks to provide a reduction in COVID-related stress, even though, again, COVID still was present at this time, but people were feeling less levels of distress. And actually, if we look here, we see that there's no significant difference between the treatment group as usual and the sham treatment. Next slide. If we look at the PTSD scale, okay, the PCL-5, again, the main difference between treatments. Okay, next slide. And when we look at the specifics, when we compare the groups, that there's not a significant difference, unfortunately, between the BAUD and the traditional treatment, okay? And that was actually also present. We didn't see significant differences within the subgroups. But again, it's indicative that there is something going on here, but we weren't able to tease out. We might need a stronger sample size, a larger sample size, or a longer intervention, or a longer, more interventions per week. But next slide, please. And so the evidence here, and that we're now looking at, is this subgroup, and I'm going to call on Dr. Leisman in a moment. But we're looking at a subgroup where we have 1 control subject and 3 of the subjects that were actively involved with the BAUD treatment. And there was a significant difference that we're going to see between these participants. So next slide, and I'll leave it over to Dr. Leisman to continue explaining now about the neurological changes that we're seeing.
Maybe you want to start with next slide, because they are repeated later. No, next slide, next slide, next slide. Before that. From the one before. Yes, application. That's key for Dr. Wallach.
Okay, so I can very briefly just say that, again, since I was going to leave over the biological stuff, so with the demands that we're seeing in the medical systems across the globe, you know, the overly pull of needing for services, the ability to give people something that they can use on their own is a pretty significant tool that we can bring into the market. that we can provide to people. And the BAUD-BPM may provide a method for individuals that manage their own levels of distress without having significant side effects, without long waitlist times, without high costs in terms of comparison to long-term medication or therapies. And it may also allow for people to avoid the development of more serious patterns or more entrenched patterns. So we can avoid perhaps people from going from a high level of stress to something like a full-blown PTSD if we intervene early. We can maybe avoid the development of presenting people to the mental health clinics because we're helping to reduce their level of stress at the time of stress. Okay, so now I'll pass it off to Dr. Leisman and my fellow presenters.
That's the beginning. Well, actually, there is no beginning and end. Because time is actually a function of the human mind, and it's only space-time that exists. That having been said, let me go back to 1905, which is probably where we need to start. The Yerkes-Dodson law, there aren't many laws in the behavioral sciences, and I'm not so sure that this one is also, but what we can say is that there's an inverted U-shaped relationship between performance and anxiety. That is, under most circumstances, not all, but under most circumstances, about 90% of the variance, Yerkes-Dodson works, which means with too low levels of anxiety, we don't function adequately. When the levels of anxiety are too high, we also don't function adequately. So what we're really trying to pull off is optimum levels of stress and anxiety to be able to allow us to perform at optimum levels. So the model that we're really talking about, as I understand it, is an optimization model. It kind of puts us into the issue of industrial engineering. And if you treat the human being and therapeutic interventions as a product, it probably makes a lot of sense. So if I can have the next slide, please. Looking at Yerkes-Dodson in another way, we can put what I've just said in the context of boredom on the one end to break down burnout on the other end. And what we're trying to do is to optimize growth and learning and decrease the likelihood of our getting into a distress zone. So we're looking at modifying human behavior in some way on the topic of anxiety and stress. Because we're talking about anxiety and stress as it relates to performance, we're really talking about the relationship between cognition and the limbic system, or anxiety itself. So that is between the cortex and anxiety. Newborn infants, and I'm a developmentalist, so newborn infants, I'm also the father of 5 kids, so maybe that has something to do with all of this. When children are born, when a newborn infant is a naive instrumental hedonist, he's interested, or she is interested, in satisfying their own needs. Sometime over the course of the first 2 years of life, something happens. That is, there is an integration of the circuitry between the frontal lobes in particular, but not exclusively, but most of the cortical regions, and the limbic system, which concerns ourselves with emotionality, and particularly the amygdala. That process of development doesn't really end until males are in roughly about age 26 and females roughly about age 23. Females' brains mature more quickly than do males, and that's pretty obvious when you take a look at our teenage children or guys, how they drive cars until roughly the age of 26 plus. The actuaries know all about this. So if I can have the next slide, please. What we do know is that stress that Dr. Wallach had spoken about is not the same thing as a stressor. Stressors are something that, as in terms of Selig's argument anyway, stressors are time limited, and we have them all the time. You're driving a car, someone sideswiped us, and you do not perceive that you are in a state of stress because you're not. You will be reactive, and after the reaction, you have a number of factors that we're trying to get a hold of associated with stress and stressors. 1, an increase in heart rate, fibrinogen level, blood clotting factor, respiratory rate, the pilomotor response, the hair stands on end, increase in respiratory rate, cardiac output, and so on. That's what we can typically call emergency reactions. We cognitively don't get on top of that until roughly some seconds after we've already reacted. However, Stress, in contradistinction to a stressor, is anything that's perceived by the organism as being physically and/or psychologically injurious to it over prolonged periods of time. So persistent stress, not only does it mess with your emotional responsivity and right hemisphere functions, such as fibrinogen production, heart rate, respiratory rate, pilomotor response, and all of that, but it also produces a hormone, and that hormone is adrenal corticotrophic hormone, ACTH. ACTH, among other things, is an immune suppressor, and associated with prolonged stressors over a long period of time, is a reduction in your capacity to fight off disease and disorder. So grandma was right when she said, don't go out in the cold without a coat in the wintertime, because you might catch the death of a cold. And we we intelligent people know that the common cold, is either bacterial or viral, not the cold, but diseases of that kind. Well, grandma was right, because our immune system is compromised. We can also say that persistent stress changes brain architecture. And here we can see the difference between, not my work, the difference between normal stressful situations or normal dendritic connectivities and toxic stress, which in particular has an effect on the prefrontal cortex and the hippocampus, and we will get to that in a moment. Next slide, please. So, I stole this from Dr. Lawless, I think. And this is a schematic, a very simple schematic of the acoustical pathway that we think. Now I'm waving, this is hand waving. I don't know this to be the case, but this is my hypothesis about what's going on, that we're able to directly modulate neural activity in the relationship between the amygdala, which is where prior to the age of 26 in males, you're pretty much reactive through the amygdala, and the hippocampus, which is where memory is initially consolidated and reconsolidated. And that, because of its connection with the limbic system, has an awful lot to do with emotional memories, which are first consolidated there, which, in other words, it derives makes connectivities between various areas of the cortex and emotional state. So what we do when we learn an emotional response, what we do when we are subjected to toxic stress, is we make connectivities that are really hard to break. So emotional memories are consolidated in this pathway we're looking at here, and it's so highly associated with, in EEG terms, what's called theta activity. That allows us to be able to examine changes in brain state that would be associated with such a device. The next slide, please. So here we have an example of brain regions that are correlated with the opposite of what we're looking at. That is, of individuals who are highly resilient versus those who are not. And we have what are called FALFF, which is an engineering term for how it is that we image through functional magnetic resonance imaging, which you see. And what we can see on the right-hand side, which is a little clear, is we have scatter plots of the correlations between these engineering modalities and psychological resilience. So it's relatively easy for us, in large numbers of individuals and participants, to be able to differentiate those individuals who are highly resilient from those who are not particularly resilient, and from those who have become more resilient as a consequence of whatever the intervention might be. The next slide, please. So now we go to the data that we've collected here, and we're looking at an assessment of the global efficiency for functional connectivity. Let me explain what I mean by that. Limited to 3 patients and a normal baseline measure before and after the BAUD treatment. What we mean by functional connectivity as opposed to anatomic connectivity is the following. Neuropsychologists, whom I have a very big issue with, for about 150 years, mostly since Broca, have assumed that certain areas of the brain are responsible for certain functions. That there's something like hemiplegia, for example, which if you're damaged in one hemisphere, your behavioral effects are lateralized to the contralateral hemisphere in the case of movement. That's nonsense. It's absolutely not true. Because if you have a damaged right hemisphere, you have a damaged brain. And if you have a damaged brain, both sides are affected. Maybe differentially, maybe different things are involved, but it's both sides. So what we're more interested in is how we learn and how the brain puts itself together functionally. And so what we're looking at is not necessarily an anatomical localization of a broad effect, but rather how bits and pieces of the brain talk to each other. That is, how they communicate. So we have here a significant difference, and it doesn't take any rocket science to see this, of the functional connectivities graphed between global efficiency and what we call a degree change between a pre-board versus after-board treatment. This means nothing behaviorally. All it means is the brain has changed as a result of board treatment, and that change is consistent over the period of time that we had measured the result. And so you can clearly see the difference between the left-hand side of the slide and the right-hand side of the slide. Can I have the next slide, please? And here we have a graphic representation of patient 1, 2, and 3 before board treatment and after board treatment. And we've done this many, many times on these 3 patients, and the results are consistent. It changes brain state. Does it mean anything? Well, prima facie, no. It just means the brain state has been changed. But in the context of the statistical analysis that Dr. Wallach, that Joe had presented previously, we can clearly say that there's a statistically significant difference behaviorally between what it is that the patients, the function of the patients prior to board treatment and after board treatment in reducing anxiety, not in affecting depression, and by extension, having an effect likely on post-trauma, and also by extension on panic. And the reason that panic attacks would be involved in such a conclusion is because panic is anticipated or anticipatory anxiety. So we know that BAUD has an anxiety-reducing effect. Why? Well, if we ever get to study the basic mechanisms in the brain about why this is happening, I will tell you then that I still would not be able to answer why, because science doesn't deal with why, but I surely would be able to tell you about what's happening descriptively, what's happening in the brain. So the conclusion is, from my end of the equation, there is a significant change in brain state. Perhaps it's related to something behaviorally or not. However, statistically, we can say that on the basis of changes in paper and pencil evaluations, that there is a significant effect. And with that, therein in the lesson.
Thank you. Dr. Wallace, you want to say a short word, because we are a little bit of the time, which, by the way, we will continue this event 15 minutes if necessary, more, because it's very, I did not want to stop the interesting explanations, because they are very breakthrough scientific explanation. But before you speak, Dr. Wallace, there was 2 questions. One from Mr. Schoenfeld in Israel, saying, "Hi everybody, I think the public would like to hear if there are any conflict of interest, at least before and during the validation research." No conflict of interest. Dr. Leisman is not part of BAUD. Dr. Leisman is not compensated in regard of the BAUD sales. Dr. Leisman is voluntary on the advisory board of M3 centers. He is on the Mental Wellness Society and have absolutely no financial relation as a result of the study. Dr. Wallach is, in fact, I've done all that study, and only after the study which was finished in September, I believe, end of September. After that, Dr. Wallach became very much involved in M3 centers, but Dr. Wallach is absolutely not involved in sales or distribution of BAUD. M3 is, on that will be our next speaker, Dr. Donkin. So there is no conflict of interest. We are very careful about that. We knew many people will ask about that, and we make sure that there was no conflict of interest. Another question of Mr. Schoenfeld: why the control patients also changed? Because we did not maybe precise. It was 2 different studies. One study was with close to 60 patients. It was the first study, and it shows there was something. And then Dr. Leisman say, well, we see there is something. Maybe to show image of it, we should do a second study, which is an fMRI. On 3 of the people who have been in the same group have been randomly selected to be part of that study. And that study is very few people, but a lot of data points. So it's very valid. And it shows the image. Without that, you will have a lot of blah blah that nobody can understand. But now you can see the image, and as we say, the photo is the proof in the pudding in here. Dr. Wallach, you have one more to say?
I have a few things to say. I think that what's really great to see in terms of the neurological, the fMRI and the QEEG data, they really show these changes in the networking that we're discussing, the communication patterns in the brain, in comparison of the before treatment and after treatment with the BAUD-BPM. So if we're seeing changes in the communication patterns, and we're seeing that in conjunction with changes on the self-report measures for levels of distress, we may not be able to explain the why, but we can say that it seems that there's something happening in the brain that is associated with the BAUD-BPM that is associated with reduced levels of distress. So there's a physiological basis, just like we'd also said, there's a physiological basis for distress, okay? When a person's heart rate goes up, there's a physiological reaction. If it's cortisol-based, if the adrenal glands are secreting high levels of hormones. So we don't have to get into the whys, but it is good to see the how, that something is going on. And this is collaborative evidence or corroborative evidence of the beneficial effect of the BAUD-BPM.
There's a question internally, I don't know if everyone can see it, from Dr. Kelly, which is, can you ask about practical applications and why timing in the brain is important to so many important functions? And the answer is, yeah, of course. So think of this. We just had a conference recently at La Sorbonne where this issue came up. Let's say, in fact, why don't you imagine a dolphin with a ball on its snout? Now, I don't know if you've ever seen a dolphin with a ball on its snout in your lifetime, but I do know that it's highly unlikely that you have. But I'm sure that in your head there's a picture of this dolphin and its color, assuming that you think in visual images, and the ball is of whatever color it is. Maybe it's red, maybe it's blue, I don't know what, but it's a color. The essential neurological problem with what I just did is that you have a circuit associated with dolphins, and you have another circuit associated with balls, and you have to get both of those into the same place at the same time in your frontal lobes and in your occipital cortex, and create a network to have them gel together. If you can't do that properly, you're probably dealing with something like hallucinations. Probably. That's not the reason for hallucinations, but it's associated with it. One example of why timing is everything. In fact, if you have a problem with timing between 2 separate systems, such as between the motor system and your decision system in the frontal lobes, you're going to be looking very much like a Parkinson's patient. Now, why would you be doing that? The answer is Parkinson's patients don't have an intrinsic problem with walking because walking is a spinal response. They don't have an intrinsic problem with decision making because cognitively, pretty much they're intact with some exceptions. But their problem is with gait freeze in many instances, which is the ability to walk and the ability to decide to walk at the same time. I can fix that easily by playing with time. The reason is they can hold a cane, and as long as they get feedback, that's for Dr. Wallach's sake, where the cane bangs on the ball of their foot, they will have no problem walking. There will be no gait freeze. That's a non-medical approach to dealing with putting multiple systems together that normally function together. It all is based on the issue of the internal timing mechanism produced by the ascending reticular system of the brain, parts of it. So your question is very well taken. What we may well be playing with here is, in the case of BAUD, is some way of messing around with timing. And I don't know that, but it's certainly an interesting hypothesis. Thanks for your question.
Thank you. So, anything more to say, or I can pass now the center to Dr. Donkin.
I think if anybody has any questions, they can definitely feel free to email us at info@BAUD.
Okay. Yeah, at the end we'll put the contact. Dr. Donkin, I need for because we speak about conflict of interest, but disclosure. There is more than 25 years Dr. Donkin and myself we have been working together and we have been friends. So the chiropractor, very well regarded chiropractor, is an author, he has done many books, he has been on many TV programs, he is regarded as one of the leading chiropractors in America, he has a big group of followers, and he has a practice where he has more than 1,200 patients a month into his practice. On his practice now is becoming M3 center that he will now explain to on his involvement with BAUD. Dr. Donkin.
Okay, well, thank you for that, Gerard, and I'm thrilled to be a part of this group. My function within the group is different than everybody else's. I was not involved in analyzing the data. I bought my first BAUD in July of 2021 and found personal benefit from it, but I'm very interested in finding out what the research showed as far as what changes were being made. And now the Dr. Wallach and Dr. Leisman have explained that very, very well, and we know that there's still more to study. But I'm looking forward to getting a practical application within my office. So if we go back about almost 25 years now, I met Dr. Meyer through some associations and through some books that I had written. He had just started and become CEO and president of the Carnegie Mellon University Driver Training and Safety Institute. And after we had several discussions, he asked me to develop the health and wellness department within the Driver Training and Safety Institute. So I sourced, this was quite a couple decades ago or more, electronic physical capacity testing equipment. So I implemented a means of studying physical capacity and studying knowledge about health and wellness, and some pre-measures and post-measures, and then a curriculum for going through the program. It was an 8-week program, 1 hour per weekday. And this was combined with the other aspects of the Driver Training and Safety Institute, where enormous amounts of data were collected and analyzed for many years to follow. So in regard to the M3 Plus Wellness Centers, I'm thrilled to have actually the first center in my office, because it's very similar to what was developed with the Health and Wellness Department at Carnegie Mellon University Driver Training and Safety Institute. So what I have here is I have a robust, lively practice. I actually, next Friday will be my 41st year of practice here in Lincoln, Nebraska. And I'm excited to keep moving forward and adding elements for what was discussed today into my practice. We, M3 Plus members so far have, we decided to do a survey of my patients to see what interest there was in things that we're talking about here. And we found, we surveyed 100 patients and had 22 questions. No name was added, or it was completely anonymous. And we found an overwhelming, response and interest to things in addition to what they were coming in here for their chiropractic practice. So in other words, people would come here for their care, but they had other things that weren't resolved in themselves that affected their quality of life. People would have anxiety about different subjects and sleep troubles, stress management troubles. And although they would get good results under care, there were still other things that they wanted. And so I didn't have to go very far to find out there's a lot here that people can benefit from if we record the data, decide what kind of a process, collection of services, if you will, could be used to help these people, and then record data along the way so that we can measure results. So we, in addition to taking vital signs here, we're going to be taking, in addition to like heart rate, blood pressure, height, and weight, we'll be doing things like taking oxygen saturation and heart rate variability, and then also assessments in the form of survey assessments or maybe some additional physical assessments, collecting that data so that then we can tap into the great deal of ability and talent that the experts within the Mental Wellness Society have, and we can call upon their assistance for certain situations. If there's something that Cody in Madrid, Spain has an expertise is, we can actually through Zoom speak with people here in my office. We could, if there's a cardiology question, we could go to Dr. Gellum in Denmark. We can tap into all of the resources that we have available in order to design approaches and measure results. So we will use what we use, like for BAUD, for example. If we have the criteria for what BAUD usage would be, we could record the number of frequency of usage in a week period. We can record the results, and we can combine that as we learn to understand what works best for people in what amount of time, and then also how can we not just get initial results, but how can we sustain that? So here in my office, it's common for me to say, get out of pain into health onto wellness. So wellness now will mean something totally transformational for my patients is what I'm looking forward to. That's very exciting for me. And then also get well, stay well. So what are strategies for people to achieve optimization, as Dr. Leisman had mentioned, and then sustain it? So we have a lot to look forward to. We have a lot to do, but I'm glad that the first M3 Plus Center is here so that I can participate in how it works, and so that we can implement it intelligently in other locations with firm data in mind.
And also, I think you want to mention that you are in M3 becoming a worldwide exclusive distributor of BAUD.
We just agreed with Dr. Lawless and his son to become global distributors for BAUD. The center of distribution will be M3 here in Lincoln.
On training also for professionals.
Right. So I'll be traveling down to Texas next weekend to meet with them in person, design the initial training protocols, and then also Dr. Lawless will come up here and we'll do filming and editing so that we can have concise, exact training modules to help professionals implement accordingly to protocol.
Thank you, Scott. I will ask Dr. Lebovits to now a few words.
Thank everybody for coming. That's number one. Number two, this has been an incredibly informative meeting for myself as well, to hear the nuts and bolts of the validation study and how it was done and the results that we have. As a clinician, which is my primary activity, in addition to being the chairman of the Mental Wellness Society, that's my primary activity. This is breakthrough. I treat quite a lot of people with anxiety disorders, panic as well. And to have a device that they can use in conjunction with, other treatment modalities, and I'll get into that in a moment, in conjunction to have a device that they can use at home, that they can reinforce the effect of the therapy can be have a profound effect. There was some, I don't know if people are aware that in the last month or so, there have been reports as to the skyrocketing number of cases of anxiety disorders, partly as a consequence of COVID, partly as a consequence of other factors going on in the world today. But it is truly a profoundly debilitating condition for many, many people. So I think the BAUD is going to be, now that we have validation data and we can actually say that this is a evidence-based treatment for anxiety, there is utilization that we can do that I think will be impressive, very, very impressive. We would like to know, I mean, from a practical standpoint, we also want to know, will BAUD actually reduce the length of treatment? Okay. A BAUD device can be used by everyone in a family, for example, and we know that anxiety disorders in an individual can certainly be impressive to the rest of the family and can generate a lot of stress for the family. And we're, now that we've done this validation study, we know that it works, and we know that it will reduce anxiety. And we also know that when you don't use it, the anxiety seems to surge again. We can continue to look for more ways that BAUD can be used, both with some of the technology from the mindful choice methodology that we've developed, that Dr. Meyer and I have developed, as well as from other technologies, to see how BAUD can be used in a variety of circumstances, different kind of protocols. So this is wide open. As a clinician, it's very, very exciting to hear just how much more has been contributed to the treatment of this particular kind of disorder. So I'm very, very grateful for all that you've done. Thank you very much.
Thank you. And I need to disclose that as we are a partner and we have been a co-founder of the Mental Wellness Society, and we created together the Mindful Choice System, the metacognitive mindful choice system, you are very cautious to recommend anything. It took more than 10 years for you to recommend mindful choice that we developed together until you were sure you could talk about it to your patient.
Absolutely.
So
ladies and gentlemen, I'm sorry to have to say that I do need to leave. It's been a great honor for me to be participating in this, and I'll see you guys soon, I hope.
Yes.
Thank you.
Take care. Be well.
So now Dr. Lebovits will never recommend any device, anything you have seen on TV, on this, on that, until we know that it has been done by an independent party, that it has been database scientifically proven, and to know that the team who did it is a team which is reliable, because Dr. Leisman obviously already have different scientific journals and medical journals who are interested to publish the result of the study. So we are professional, all the professionals can now recommend their clients to get on, knowing that they are not compromising their reputation. And definitely with the study, it opens the door for us to eventually look at how it can be proved by the drug administration in America, FDA, Food and Drug Administration, because it's a device which none of the devices on the market are proven to be effective. But maybe the you have some ideas of other utilization. You know.
I'm afraid I'm going to have to go. I'm sorry, Dr. Kelly. I'm sorry to interrupt, but I'm afraid I'm going to have to go as well. I look forward to hearing the rest of this, and I look forward to more meetings in the future.
Yeah, it's recorded.
Thank you.
And that's the beauty of it.
Take care. See you.
Thank you. Thank you very much. It's really interesting to me. I'm a clinical neuropsychologist and a licensed clinical psychologist, and I've been working in developmental neuropsychology for more than 30 years now. So I am very interested in the potential practical applications of BAUD. I've used other timing devices, one that's similar but not as convenient as BAUD, and combines timing and sound, but not in the way that BOAD is doing it. So I'm very excited to have the opportunity, I hope, to try this out myself, and but also to study practical applications. Just to let you know, I have no association or affiliation with Dr. Lawless, or I should say, or his son, and I have no financial interest in this whatsoever. I'm just a clinician that is the chair of the Parenting and Education Committee for the Mental Wellness Society. But I am someone that had spent over a decade studying cancer patients and the cognitive effects of cancer patients, as well as working with autistic individuals. So, as you know, Dr. Leisman was describing timing mechanisms, and I just wanted to take a moment to bring the lab to the laptop, if you will. As a neuropsychologist, I'm always interested in interventions like BOAD because it has so much to do with timing. And sound and timing is something that our brains are exposed to and trained by even before we're born. It's the first sense that we really tune into when we're in the womb. So it makes sense that as we grow and develop, our brains are highly controlled and highly sensitive by sound, which can neurologically have an impact on your timing mechanism. If you think of your brain as a computer, and yes, for my colleagues out there, I apologize, it is an oversimplification, but this is how I communicate to the people I actually work with. If you think of our brains as a computer, deep inside, there is a processor, and that processor kind of works like the processor on your computer at home. You know, we all love the speed and efficacy of an Intel processor, right? How frustrating would it be if our internal processor was an old DOS model, right? So when we talk about processing disorders, we talk about disorders of attention, anxiety, stress, panic attacks, many of those have been studied already in terms of how they relate to timing disorders in the brain. So that is why I'm so excited as a professional about the potential of BOAD and the many ways that I hope we can study it for practical applications with many different populations that can benefit from it. Thank you.
I'm interested to see if there is not some positive effect for diet, for making diets, particularly mood on gut relation.
So what we also know, there's already been a study with another intervention that's not like BOAD, that's cumbersome, you have to go to a clinic, about timing and sound that's been done on our veterans. This goes back to 2015. So we know that sound and timing has effect on mood, on PTSD. And we also know it has a very big effect on attention and executive functioning. So the basis of this research is here on how timing affects us in so many ways. What BOAD is going to allow us to do is to see how it can be, I guess, implemented without the middle person, without having to go to a clinic or have a professional mediated for it.
Also, you told me, Dr. Kelly, that you wanted to see if there is any positive effect on alcoholism and different things. But we have an idea to use it in Ukraine, because in Ukraine there is a lot of anxiety and PTSD, and we have been very much involved, and we have acquired M3, acquired different units to test it in conjunction with our colleague in Ukraine. I also will have contacted different organizations in Israel helping lone soldiers. They are soldiers with no family, nobody coming in Israel, and they are a high rate of suicide. And we believe that, and they have a lot of anxiety and a high rate of suicide, and we believe that both could be efficient. I heard from Dr. Lawless that it could be also efficient for what we call Havana syndrome, because there is an effect on the brain. because it's the area of the brain where you make decision, the effect of BAUD, on the area of the brain where you make decision on choice. So that's very important. But I also realize that we have tests for procrastination, and one of the procrastination marker is anxiety. So it should certainly help in efficiency and anxiety. Anyway, I'm planning to make next interview with Dr. Let's wait the end, Sherry. I'm planning to make a next interview with Dr. Lawless. He will be now our last speaker, but it's very obvious that BAUD is becoming a tool for resilience, and resilience to modern life, because there is modern stress and there is modern societal issues, and anxiety because we are in an uncertain world. And this is really something where now we can propose BAUD not as a long shot, and not saying, well, maybe these things work, they say it's good. Now we can compare, because we have control groups and we have scientific study to validate any new study we will continue. With that said, I would like to introduce Dr. Lawless, because Dr. Lawless is the inventor of BAUD, and I want to congratulate him for many, many, many years, I don't know, 30, 40 years, where he claimed he had an invention, and everybody was saying, yeah, sure. Well, now we can say, we did not have the equipment to be able to measure and to show that he was right. We did not have a motivated team to look into this. We did not have a team to finance it either. But everybody came together, and we were able to prove that, yes, he was right. So, Dr. Lawless, please tell us what is your state of mind of what you have heard. Tell us a little bit about what we share today. What do you think about it? And if Dr. Lawless cannot talk, his son Tiff Lawless can speak for sure.
Absolutely. I think we're pretty excited. I know Dr. Lawless is super proud we've been working with this product, and we've had significant positive results over the years. And I'm not the psychologist. He came to me many moons ago and said, "Can we build something to do this?" And that's the kind of thing that I do. And so we built that. But yeah, I know that he's excited to hear these results and to have such a foundation of thorough investigation of the product that we've been so excited about for all this time. So thank y'all very much.
Thank you. I think nobody's mentioned it, but BAUD is sold for approximately a little bit less than $500. It's a handheld system. I don't think it has been indicated that the specificity of BAUD is to be a binaural signal, meaning left ear, right ear don't get the same signal, which facilitate to get in a certain wave brain, which facilitates the change. That was not said. And also for what profession can use it. Obviously, individuals can purchase BAUD, but for themselves and their family. But we have psychologists, mental health professionals, chiropractors, as we see, physical therapy, social workers, trauma centers. A lot of profession are concerned with being able to help, and I'm sure educators too, with what BAUD can do. And what we will do, obviously, we collect data and we are engaged in communication. That's what does the Mental Wellness Society worldwide. We want to know new application on new things which have been done, and eventually it will be for us a ground to make more study, because now we have a control group with a group which have been under BAUD effect, and we can compare when we do whatever we do with that group. And this is a treasure, because the same group in Cuba, and the same under the leadership of Dr. Leisman, which, by the way, is in the laboratory in Cuba and the laboratory in Haifa in Israel. He's the head of all the research. So he's continuing with the same team. And I want to thank the team in Cuba for the magnificent job they have done. And they have amazing equipment. They are certainly one of the centers in the world with the most advanced equipment that their government is providing for healthcare. So with that said, any one of you have anything to add?
I just wanted to add something that, you know, in the past, the way that we treat anxiety has really been, you know, largely treating the symptoms of anxiety. And I believe with BOD, we have an opportunity to actually go to the source of anxiety and not just treat the symptoms.
Thank you. Thank you very much. I will ask Celeste to put the last slide. Okay. So any information, any question, anything you want to do, any follow-up, if you want to receive a copy of those two studies, you write us an email at info@BAUD-BPM.com. And I promise you we will answer promptly. With that said, I want to thank all of you. We have spent close to a year in that research. And I want to thank everybody who was involved. And today was exciting because it shows coming together from different parts of the world, different specialties, different skills, including producing the board for Tiff. Coming together makes a big toolbox. There is not a multinational company. And this is a pride of necessity to have experts in every field to improve being. Thank you for being with us. Next link in live will be with Dr. Lolis himself. Speak about his invention. Thank you so much. Greetings from Israel and from your different parts of the world.